everyone. I am Dr. Shreya Jain, first year postgraduate junior resident in the Department of Physiology at JIMS Greater Noida. I will be presenting on the topic lung compliance, which is synonymous with distensibility of the lung. It is defined as the change in lung volume per unit change in transmural pressure gradient, which is the transpulmonary pressure. It is represented as delta V upon delta P. Normally it ranges to about 200 ml of air per centimeter of water transpulmonary pressure. It is inversely proportional to elastance. Now we see this phenomena by the example of two rubber bands. If it is a thin rubber band, it will have small amount of elastic tissue and hence will be easily stretched, will be distensible and compliant. If it is a thick rubber band, meaning it has a large amount of elastic tissue, it will be difficult to stretch, less distensible and less compliant. Why? Because it will show a greater elastic recoil force. It will tend to preserve its original shape. Now it is of two types. If it is measured with lung held at fixed volumes via an external apparatus with a vacuum pump and a spirometer, then what we calculate is the static compliance as shown in this graph. But if it is measured during the normal rhythmic breathing at the end expiratory and the end inspiratory no flow point areas, then it is known as the dynamic compliance. Now coming to the compliance of lungs as a whole. This graph represents the pressure volume loop. Pressure volume loop shows that there is a difference in both the limbs for inspiration and expiration, or we can substitute these terms for inflation and deflation. As we can see, the slope of the pressure volume loop, that is delta V upon delta V, is what that gives you compliance. The pressure taken is the negative pressure, which is the intrapleural pressure present outside the lungs, and the volume of air that is inhaled and exhaled subsequently. So now, as you can see, that compliance is low at the low lung volumes, but it is also low at the higher lung volumes. Why? Because of the phenomena of surface tension and elastic limit. The phenomena that the both curves differ and the slope of the relationship differs is known as hysteresis between the inspiration and the expiration limb. For a given outside pressure, the volume of lung is greater during expiration, and hence volume is directly proportional to compliance. Therefore, compliance is more during expiration. We will see this here. During inspiration, what is happening is there is low lung volumes. Because of those low lung volumes, the liquid molecules are closer to each other. So to inflate the lung, more work needs to be done. And as we are expanding the lungs, or as we are expanding the alveoli, the surfactant becomes less concentrated and the surface tension increases. And as we know, surface tension is inversely proportional to compliance. More the surface tension, harder it will be to distend the lungs. Now the surface tension is countered by the presence of a compound known as surfactant, which is your dipalmitoyl phosphatidylcholine secreted by the type 2 pneumocytes. It breaks apart these forces which exist between the intermolecular liquid molecules of the alveoli and provides chance for the small alveoli specifically to remain inflated and have a low collapsing pressure, hence increasing their compliance. Now during expiration, which is actually a passive process, the complete opposite occurs. Here, as the alveoli contracts, the surfactant gets even more concentrated. If it's concentrated, the surface tension will decrease and hence compliance increases. Compliance of chest wall is another thing. Compliance of chest wall is that the negative intrapleural pressure created by the two opposing forces, which are the lung with its elastic properties who wants to collapse and the chest wall with its elastic properties which wants to spring out. So this negative intrapleural pressure created between both the surfaces holds the lungs open and keeps the chest wall from expanding too much. But this goes all haywire in a condition known as pneumothorax. Here what happens is the intrapleural pressure becomes equal to the atmospheric pressure because of an external puncture from the chest wall to the lungs. The lungs now collapse and the chest wall springs out as the negative intrapleural pressure no longer exists. Now we'll discuss upon the compliance of the combined lung and chest wall system. As we can see from the pressure volume graph that the combined compliance of lung and chest wall is less than that of lung alone and that of chest wall alone. We can see that from the graph when the volume and the pressure coincide, that is the pressure is equal to 0 and the volume is equal to FRC, that is the functional residual capacity, which is the resting volume or the volume which is left after normal tidal expiration. It coincides with the atmospheric pressure, and hence the collapsing force and the expanding forces are completely balanced. But when the volume is less than functional residual capacity, for example in case of forced expiration into the spirometer, the collapsing force decreases and the expanding force increases. Now the atmospheric air will flow into the lungs down the pressure gradient. Similarly, when the volume is more than functional residual capacity, for example when a subject inspires from a spirometer, the collapsing force will increase and the expanding force will decrease, letting the air flow out of the system into the atmosphere down the pressure gradient. We can also see the phenomena that at highest lung volumes, both lung and chest wall actually want to collapse because of the effect of elastic recoil and elastance. Now coming to some applied clinical aspect, we have two disorders like emphysema and pulmonary fibrosis. Emphysema is associated with loss of elastic fibers, and as we know, elastance is indirectly proportional to compliance, so the compliance increases, and as compliance increases, there is also the tendency to expansion. Now, in order to balance this out, the functional residual capacity will increase, and therefore the person will breathe at a higher lung volume and therefore are seen with barrel-shaped chests. In case of pulmonary fibrosis, which is a restrictive lung disease, we will see the stiffening of lung tissues, that is increased deposition of elastic and collagen fibers, so compliance decreases and the tendency to collapse increases. Now to balance this out, the functional residual capacity will decrease, and this is also visualized in these graphs. As we can see, if this is the normal lung and chest wall compliance, in emphysema the FRC increases and hence the graph also increases, whereas in fibrosis the FRC decreases and the graph henceforth decreases. The equilibrium point shifts basically. And another thing which we can talk about is neonatal respiratory distress syndrome, which is characterized by either no or low amount of surfactant. This is seen in case of premature preterm births, usually less than 28 weeks. What happens here is that the small alveoli, with their high surface tension and increased pressures, they collapse because of the absence of surfactant, and this is known as atelectasis. So no gaseous exchange occurs. The infant lands up with hypoxemia. Without the surfactant, the lung compliance decreases and the work of breathing is increased, and since also the surfactant keeps the alveoli dry, now there will be pulmonary edema as well. These were my resources for this topic: Linda Costanzo Physiology 7th edition, West Respiratory Physiology 11th edition, Nuns Applied Respiratory Physiology 8th edition, Guyton and Hall Textbook of Medical Physiology 2nd South Asian edition. Thank you.